Hi everyone, this is the start of Module 3, talking about assessment and diagnosis for psychopathology and abnormal psychology. This is one of my favorite modules because it touches upon one of the key roles of psychologists and other mental health professionals in terms of assessment. So the idea of usually asking lots of questions to better understand people, better understand kind of what types of symptoms and what types of issues they're experiencing. And in certain cases, in certain settings, deciding whether those symptoms warrant a diagnosis and kind of what to do from there. So we're going to talk about the goals of assessment today in this part of the module, and really, any assessment that psychologists or other mental health professionals do generally is based on a referral question, or is based on kind of assessing some treatment goals that have already been set up. This referral question may be something that is something from the client themselves. So they are wondering, whether or not they have a particular type of disorder, or they're just coming in for therapy and kind of trying to understand how best to deal with depression or anxiety. Sometimes these referral questions can come from other professionals. These could be from health settings. These could be from schools. There's lots of other places where we might get referral questions. And we'll kind of talk about some of those scenarios. So I think it's important to mention that the goals of assessment really kind of boil down to these three main pieces, three main goals of doing these different types of assessments. So we have screening, and usually that is broader types of assessment with larger groups of people. I'll kind of talk about some of the situations where screening plays a big role. Diagnosis, which involves assigning a label to someone based off of whether they fit certain criteria for a particular type of psychological problem. And we'll kind of talk briefly about what that label might mean. And treatment planning that stems from that diagnosis. So we would do an assessment, come up with the diagnosis, and based on those things, we would also develop a prognosis, which is the idea of kind of a future outlook for that person, and develop a treatment plan. And related to that last idea is the third goal of assessment, which is outcome monitoring and evaluation. So that's understanding how well our treatment is working and evaluating the overall treatment effects that we have. And that could be for a single person, or that could be for a group of people, for example, in a clinic or in a school or something like that. So screening for mental health problems is a really crucial aspect of assessment. And screening, again, is something that is broad, that is meant to be kind of done for a lot of different people. And so screening tends to happen where there's a lot of people that sort of need to get, tested or need information about their mental health, or where the practitioners working there would find information about mental health useful. So this includes places like hospitals. And I think I mentioned, I don't know if I did on my message, but I did end up in the ER last week as part of my accident. Again, things are okay, but if there's someone coming in with kind of odd behavior, odd speech patterns, doesn't really seem coherent, is talking about, ideas of persecution, meaning they think people are out to get them, that might be a place where mental health screening would likely happen. Inpatient psychiatric units kind of related to that, where there's an initial screening that's needed to happen so that the treatment team can best respond in the moment to that person's kind of most pressing concerns. Sometimes inpatient psychiatric units have a little bit more information first, but sometimes screening is needed. Community health centers. So this is not traditionally a strong suit of community health centers in terms of doing screening, but more and more as we've sort of realized the importance and sort of realized the need to get our assessments out there, and the more and more community health centers are seeing mental health issues, they're starting to do different types of screening assessments. So they may work with families, work with individuals who are getting other types of resources, but they may be doing screening for mental health, and then they could potentially make a referral to a psychological agency or something like that. Schools are really heavily invested, a lot of schools, I should say, are heavily invested in screening for mental health problems. So we actually have researchers and clinicians here at Utah State University in the psychology department that focus on screening for mental health problems, including things like autism spectrum problems, including academic well-being and other mental health problems. And there's different levels of screening that might happen. And so one of the really the broadest level would be universal screening. So this may be every student in a school or every student in a grade or every student in a classroom would receive a screening measure, receive some screening questions about their mental health. And the goal of that would be to decide, again, who are the kids that maybe need some more resources, maybe need some follow-up attention in terms of their mental health. And outpatient services are services where psychologists, often work that are more kind of office-based, kind of the weekly sort of therapy visit type of setting that people may have seen or heard about. And, when people are coming in initially and sort of saying, I would like to meet with you, to meet with the therapist, screening may be done to sort of identify whether the psychologist is best suited to help them to kind of understand what are the most pressing concerns. So screening would maybe be the first step in a longer process of assessment. So I just wanted to point out a couple of examples of screening assessments, and your book does a nice job of kind of talking through a few examples of screening questions that may happen for depression and anxiety. But I wanted to point out a couple of evidence-based assessment measures that are out there that you can find online really easily. You can Google these, and you can check these out if you want more information. The PHQ-2, the Patient Health Questionnaire 2, is an example of a validated questionnaire, validated screening questionnaire for depression. When I say validated, really what that means is that there's some evidence, research evidence, to back up its use, to support its use for screening for depression. And the two big things are validity and reliability. And I talked a bit about those in the research methods module last week. We'll talk more about them for measurement coming up in a subsequent lecture post. But the PHQ-2 is really a first step approach to, again, understanding whether someone may be experiencing depression or may be at risk for depression. So it asks about the frequency of depressed mood and anhedonia over the past 2 weeks. Anhedonia is the idea that a person has maybe lost pleasure or interest in doing things that they usually like to do. So if your passion is playing the piano, or if that's one of your favorite hobbies, and that's not something that you've been doing the past 2 weeks, that would kind of potentially indicate risk for depression. And so a person would be administered this questionnaire, meaning they would be given this questionnaire and be asked to fill it out. And they're filling out basically over the last 2 weeks, how often have you been bothered by the following problems? Little interest or pleasure in doing things. Again, that means anhedonia. That's kind of what that term means. And then feeling down, depressed, or hopeless. So this is really the mood component of depression. And you can respond not at all, several days in the past 2 weeks, more than half the days in the past 2 weeks, or nearly every day. And people are responding to that, and each response, depending on what you pick, you kind of get a certain amount of points for that. And screening instruments, based on research, you add up the points usually and get an idea of where that person falls. This is an example of a standardized measure, meaning that you're comparing a person's score up against kind of a benchmark or a threshold, comparing it up against a lot of different people that have already received this questionnaire before, again, ideally in a research setting. And so what this measure kind of says is that if you score 3 or greater, it means that you potentially have major depression. It means that it's, the way that it phrases it is that it's likely. And again, that's based off of the research evidence using that threshold of 3, that score of 3, as being the marker for someone having depression versus not. And we'll talk a bit about that in just a minute with sensitivity and specificity. So that's a PHQ-2. The other one I wanted to mention briefly is the GAD-7. For those of you who either, hopefully you did both, but for those of you who participated in the online survey that I put together, that was a demonstration for the class. For those of you who watched the lecture on group-based research, You might remember the GAD-7, measure of generalized anxiety symptoms, and 7 questions, kind of similar wording in terms of the time frame. So over the last 2 weeks, how often have you been bothered by the following problems? And you have the same type of response options. Some of the questions are things like feeling nervous, anxious, or on edge, worrying too much about different things. That's one of the hallmarks of generalized anxiety disorder is you're not just focused on one thing or one worry. It's you have lots of different worries. Becoming easily annoyed or irritable. So those are some of the questions that are on the GAD-7. Again, people are basically writing their responses down, and the clinician or an office manager or someone involved in whatever setting this is being administered in is scoring this measure. And it gives some thresholds in terms of different markers for severity of generalized anxiety symptoms. So if you score 0 to 4, again, this would be the total that you get here. If you score 0 to 4, it's minimal anxiety, 5 to 9 mild anxiety, 10 to 14 moderate anxiety, 15 to 21 would be severe anxiety. And we get some indication here about functional impairment. And what that means is that how much is this set of issues getting in the way of your life, your relationships, your work, your school, how your life is going, basically. So some of you may remember some of those questions from the demonstration survey that I did. So this is another example of a screening instrument that is widely used. This is public domain. You can feel free to check this out. It's easily, you can easily find it online. So let's get back to this idea of really what screening instruments give us and sort of how we get to those thresholds or scores that I mentioned that are used. And again, the idea here is that a score of 10 on the GAD-7, that's the one that's that we have from the literature, a score of 10 or higher, 10 points, would be an indicator of potentially having generalized anxiety disorder. And again, taking great pains to say it doesn't mean that you have generalized anxiety disorder if you score above a 10 on the GAD-7. It doesn't mean that you have depression, major depression, if you score a 3 or above on the PHQ-2. It means that you potentially have it. It means that it's more likely if you're scoring at that level. So how do we get that information? So I want you to first just kind of ignore this part over here. This is kind of a follow-up question, and just focus on figure 3.2. This is coming directly from your textbook. So this is a key table that I'd like people to really spend some time thinking about and sort of looking at, what is this table telling me? And I'll take some time here to talk about it. So with screening tools, really with any assessment measure, but especially with screening tools, we're thinking about how that screening instrument, how those questions are giving us information about the likelihood of a problem that person may be experiencing. And we're trying to maximize it, our ability to say that a person has depression when they do. And we're trying to maximize our ability to say that the person doesn't have depression when they really don't. So it's a bit of a complex idea. So let me kind of break that down a little bit. So the first thing to mention is that really, we need to kind of go through a process to arrive at a point where we have an instrument that we feel confident in its sensitivity and specificity. When we feel confident in its ability to identify people that have depression or don't have depression, for example. When we first start out and developing screening instruments and developing, again, something like a PHQ-2, that questionnaire in itself can't really tell us much. We don't know exactly what the scores mean when we give someone that PHQ-2. So we have to start out with some research to first kind of understand that. Now, the first piece of information that we need to have is what is the person's status in terms of actually having that problem. So for example, our question is, does a person actually have depression? And the two different options here in this type of framework is that either depression, yes, it's present, or no, depression is absent, it is not there. And so with this, again, when I say that the screening instrument can't give us this information, what I'm saying is that we don't really know when we give someone a PHQ-2 whether they really have depression or not. So that part is really kind of crucial that you understand. So when we're first testing out these types of measures and screening instruments, we first need to have a really good assessment, a different type of assessment, like a diagnostic assessment, a gold standard assessment, using all available information getting a lot of background data to say, yes, this person has depression, or no, this person does not have depression. So again, we have really, hopefully, solid data for this piece that is collected through a more detailed process. Now, when we're talking about screening, this kind of side is what we're talking about. So the person is filling out the PHQ-2 or the JD7, and what we're trying to get out of that instrument, out of that measure, is basically what score, or does that score that they get signal that they do have depression, or does it signal that they likely don't have depression? So those are, again, kind of the two potential outcomes. So we can either have a positive result on that screening questionnaire, meaning once we have a threshold that's established, or as we're establishing a threshold, we're saying that a score above whatever number we're looking at suggests that depression is present. So again, on the PHQ-2, that score would be a 3. The score of 3 or above suggests that depression is present. And when we're talking about negative, the score suggests that depression is absent. So again, the research has shown, and the process developing the PHQ-2, scores of 2 or less on that measure, on that 2-item measure, indicate that depression is absent. So again, it's suggesting that depression is not there. But again, we need to go through a process of testing out that question, of finding the best cut point, finding the best threshold. And again, through research, they found that 3 was the best score for differentiating people who are depressed versus people who are not, or likely to depression versus likely not depression. So again, hopefully you kind of understand that there's a cycle that needs to go in to play through the research process to get to what we saw with the PHQ and the JD7, where they had thresholds that are kind of identified as being the best ones that we use. And in doing that, really what researchers are trying to do is to maximize sensitivity and specificity. So when we're talking about sensitivity, and we can kind of think about 4 different quadrants, and there's 2 ways of getting the situation right, and 2 situations that we can get the situation wrong. I mean, our answer from the test is right or wrong in terms of mapping onto reality. So we can be right in that the score that we get from the measure is accurate in reality, meaning that our score is suggesting that the person has depression, when in reality they do. So that's one way that we can be correct. The other way that we can be correct is that the score that we get suggests that the person does not have depression, and in reality they don't have depression. So again, that's a negative score. The score suggests depression is absent, when in reality when is absent. So that's specificity. So we're trying to maximize sensitivity and specificity, our 2 right answers, when we're doing the development of these types of screening questionnaires. And we're trying to minimize our misses, and there's 2 different ways to miss. We can get a false positive, meaning that our measure suggests that depression is there when in reality it's not. Or we can get a false negative, meaning that our measure suggests that depression isn't really there, when in reality the person actually does have depression. So we can have a false positive and a false negative. And again, really what we're trying to do when we're developing instruments is to try to be the best at all of these different things. We're trying to maximize sensitivity, maximize specificity, minimize false positives, minimize false negatives. And as we get more sensitivity, as we get more specificity, we're naturally decreasing the false negatives and false positives as well. So these are kind of related indicators. So again, what I want people now to think about is the different scenarios that come up with assessment, and really helping to think about the screening process in particular, maybe comparing it. You can maybe kind of take this question into the next slides with diagnosis, but what aspects of accuracy do we want to maximize in screening, versus in diagnosis? So which one are we kind of saying is the most important? Do we want to maximize sensitivity or specificity when we're doing the screening process? Put another way, what type of error is less desirable or more problematic in a given situation? Is a false negative more problematic, or is a false positive more problematic? And so that's something that you can take a minute to think about, pause the video if you'd like, or you can kind of follow along as I talk through a couple of ideas about that. So it's hard to kind of say that there's one absolutely right answer, because it does depend on what type of situation you're you're in and sort of what the goal is of your testing. This actually has come up a lot in terms of COVID testing when initially, well, there were some measures that were bad at both, measures that were, or tests for COVID that actually were just wrong. They were inaccurate, and maybe less accurate than kind of what is desired. And then there's tests that have been developed that are really accurate, that really do a really good job of identifying when COVID is there, and measures that really, do a good job of kind of ruling out um, that COVID is not there as well. So it really maximizes sensitivity and specificity. Those tests tend to be more expensive and kind of take longer to get the results. So there's more measures that have been coming out where they're faster. You can kind of do them, on a daily basis even, and get results quicker. And one of the critiques is that, well, they're maybe less accurate. Maybe, if they give you a positive result, maybe that's not actually true. Maybe you don't have COVID. It's just the test kind of giving again, that would be a false positive there. People would argue that in this case, maybe that's okay because people are more likely to follow up with additional testing. They're more likely to take precautions versus, again, some of the issues that have come up when we try to use the more expensive tests that take longer. So similarly, when we're thinking about the screening process for mental health, we might want to think about maximizing sensitivity. The idea that if depression is potentially there, we want to try to capture that. And we might think about kind of a net, that we want to try to capture those potential cases in our net. So think about the idea of administering the PHQ-2 to to everyone in a high school, for example, to all the teenagers in a high school. And the idea there is that we kind of want to get in any potential positive depression case that's there through our screening instrument. So we want to maximize the sensitivity. What that means is that we might actually get some more false positives. That with that score, we might actually say, this person scored a 4 on the PHQ-2, but in reality, they're not actually depressed. So again, that could be one way that it would look. So again, the score for the PHQ-2 is solid. It's backed up by evidence, so that's not one that we would be concerned about. But for a new measure, that would maybe be the thing that we're talking about. And specificity might matter more when we're thinking about diagnosis. The idea of kind of ruling out the idea that someone doesn't have that problem if we're going to give a diagnosis. That would be really key, right? So we don't want to give a diagnosis of major depressive disorder if a person really isn't experiencing that. So really with diagnostic assessment, in general, we're doing pretty good at both of these if we're doing the assessment right. But again, with screening, I think it's especially important to think about sensitivity. And with diagnosis, it's especially important to think about specificity, being able to rule out that the person doesn't have that condition. And again, different measures have different thresholds, and researchers are trying to balance these two kind of ideas in terms of what they come up with for what their threshold is. Let's transition now to diagnostic assessment and talk about this kind of other scenario in which assessment is a really key kind of aspect of practice for mental health professionals, including psychologists. So diagnostic assessment is supposed to be really, really detailed. It's supposed to take a substantial amount of time. Again, there are limits to that. We have to make sure that we're not, taking all the time in the world. But there is a big difference between the amount of time that we expect in a screening process versus what we expect in a diagnostic assessment. So screenings are supposed to be fast. They're supposed to be, as little burden as possible to people. Diagnostic assessments tend to take more time. So screenings may be a matter of minutes, and diagnostic assessments may take hours. They may take multiple sessions of a person coming in and doing testing, and so it can sometimes take up to even like 8 or 10 hours depending on the referral question. So when we're doing diagnostic assessment, we're generally evaluating symptom and disorder severity by asking lots and lots of questions about what a person is kind of going through. We tend to start out pretty open-ended, questions like, what brings you in? What are the main problems that you're experiencing? And kind of narrow it down from there. And we try to make sure that we don't close off any doors. So we'll talk about kind of how the structure of assessments can help with that. But we make sure it's a very thorough process for asking about a lot of different types of things. We ask about patterns of symptoms over time. So that's the number of times a problem has come up, the frequency, so how often per day, for example, how often per week, how often do those episodes last, and has that problem stayed the same over time? Is that a recent development? Has it gotten worse? Has it waxed and waned over time? Meaning, maybe you experienced that type of problem 6 years ago, and then it got better, and it came back recently, maybe like a few months ago. So we're looking at patterns of symptoms over time. You can think about, a behavior problem that children may face, like tantrums. That one's pretty easy to understand in terms of the types of questions that we would ask. So, how many tantrums per day is the child having? Uh, um, again, is this daily? Is this weekly? What does that look like? How long do those tantrums last? So my son's tantrums have gotten to be higher in frequency over the past couple months, and they last a little bit longer. So still normative. He's not at the point where he's having a serious problem yet, but there are days where it feels like it for sure as a parent. He's doing great though. So those would be the types of questions that we would ask about the patterns of symptoms over time. Psychology, clinical psychology in particular, has a pretty notable history of really just focusing on weaknesses, focusing on deficits that a client or a patient is bringing. So it's really important that as part of a diagnostic assessment, we're bringing in a patient's strengths as well. We don't want to discount those. We want to make sure that we identify those, that we integrate that into the patient's notes, for example, into our assessment write-up. We may use something like behavioral assessment. It's really standard practice to include some sort of observation, even with telehealth, even if we're doing it over the web. We need some sort of observation. We need to see the client and kind of make some notes about their mental status, kind of what we observe in terms of their mental status. But we may also do more in-depth behavioral assessment, either related to their problems or have them do some self-monitoring, for their problems, things like that. Diagnostic assessments really differ in terms of how structured they are. So they range from structured to unstructured. And then there's a middle ground of semi-structured. So structured assessments, diagnostic assessments are usually more used in research for research purposes, because we really want to be sure that each assessment is done as exactly the same as possible. They're less used in typical clinical practice. But basically you ask the questions a certain way, you ask them in a specific order, and you don't really kind of change anything up. You don't deviate from how those questions are asked. Excuse me. With semi-structured assessments, there's a little bit more flexibility. You can ask questions in different ways. You can change up the order. You can only ask, subsets of questions if it makes sense to. So more flexibility there. And then there's unstructured assessments, which really rely on the clinician to have a lot of expertise and experience with different types of problems for them to be able to do it well. One of the biggest critiques that I think there is of unstructured assessments is that we end up running into issues both with the validity, really the accuracy of our conclusions, and also reliability. So those two things are related with this idea. So picture a scenario in which someone is coming in to see me to get an assessment, diagnostic assessment, and I go through this full process, but really rely on unstructured assessment. So you're talking about depression. I'm going to ask you about what I think is important for depression assessment. And I don't really go off of anything that's, has any sort of structure for that. Just use my best judgment in doing that. Let's say that same person goes to see another professional, another psychologist, and that person does their unstructured assessment pretty differently. If we reach a different conclusion, we run into problems with reliability. And this is a specific type of reliability, which would be inter-rater reliability. And so basically, if myself and that other clinician get to different conclusions, there's inconsistency in terms of what we're kind of saying is the issue. And that leads to problems with validity, right? That we can't have a valid conclusion if there's inconsistency. At least it would be hard to think of it as being valid. So I tend to fall in this direction of liking semi-structured interviews because there's some flexibility while also providing some nice structure. There's some examples of structured interviews that you can take a look at if you'd like to. Some of them should be available online. So one would be the KSADS -PL. That's a semi-structured interview for childhood mental health problems. That would be one that would be relatively easy to find. I'll see if I can post it on Canvas as well. And then there's a lot of other ones that kind of are in this direction as well. Diagnostic assessment ideally will include collateral report. And what collateral report means is that we get information from someone other than the client themselves, so a family member, a significant other. A work colleague would be uncommon, but could work if that works. A friend or roommate, again, we need to have approval from the client and the patient to be able to do that because of confidentiality reasons and our ethical obligations. But collateral report can be really beneficial. It's a natural part of the process when we're working with families and working with kids. So we would get parent report and child report of a particular type of problem, assuming the child is old enough to report on what's going on for them. We may get neuropsychological testing. Neuropsychological testing can give us lots of types of information. So it may include things like processing speed, working memory, verbal fluency, lots of things like that. And we can also get personality assessment data. We can that can be applied specifically to personality disorders, but we might also just want to kind of understand someone's personality profile and how that plays a role in what's going on for them. So it may include, and if there's enough resources, hopefully does include all three of these different components. But again, sometimes resources in a setting can be pretty tight, and time is a resource, and so sometimes it's hard to get the necessary amount of time to do everything here. But that's a balance that clinicians have to face. Wanted to just mention kind of a note on differential diagnosis and comorbidity, because these are related issues, but different. And I wanted to help you to kind of think about what each of them means. So differential diagnosis is really the idea of developing hypotheses about what type of label or kind of cluster symptoms would best explain what the client is reporting and experiencing. And so what we're doing there is we're saying, there's a couple of potential different disorders that might explain this set of symptoms that this person is experiencing and their related impairment. So I have to make a differential diagnosis, meaning I have to kind of choose one diagnosis over the other. I have to say, this is my kind of the diagnosis that's most likely. And so one example of that would be something like, and again, I mentioned the emergency room. But let's say a person is coming into the emergency room, they've been behaving erratically, maybe they were injured, or maybe they were kind of spoken to by the police, and the police decided to take them to the ER. And there are physicians working there, and they're trying to understand, and hopefully they get some consultation from a psychiatrist or psychologist to say, we're having trouble kind of telling what's going on. Can you do an evaluation or an assessment? And in this case, there's a couple of different potential explanations. So one would be the person is potentially having, and let me go back and just add one detail real quick. So again, I mentioned the idea of erratic behavior, kind of maybe there's odd speech patterns, and maybe the person is coming in and saying that, that they're being watched by the government, that the government is following their every move and, tapping their cell phone line and watching their social media posts and all of that. And so they have ideas of persecution. Maybe they kind of feel like someone's out to get them. So that person comes into the ER with that set of symptoms. The physician gets a consultation. The psychologist or psychiatrist or whoever is kind of helping with that is kind of trying to decide, is this potentially an acute psychotic episode? Is it reflective of schizophrenia? Or is it potentially psychosis due to some sort of substance? Have they been doing drugs? And that's kind of what led to this issue. That can be difficult to disentangle sometimes, especially if you don't have a lot of information about a client. But that's a type of differential diagnosis that practitioners have to make, that clinicians have to make. Comorbidity is a little bit is different. It's still kind of based on the idea of developing hypotheses, but It's the idea that problems can co-occur. So we don't necessarily have to decide that it's schizophrenia versus psychosis because of a substance, and it's either one or the other. But comorbidity is the idea that in certain cases, there are symptoms that may reflect co-occurring psychological problems or psychological disorders. So one really common example of that would be depression and anxiety, that we see a person has been feeling depressed and hopeless, feeling blue, low mood, that they have not been eating as much as usual, moving more slowly, kind of not being able to get out of bed, little interest in life. So that would be kind of one set of symptoms, maybe indicating depression. And they've also reported anxiety around lots of different situations, and kind of physical symptoms around, maybe upset stomach or sweating or heart palpitations, racing thoughts. So we may there be thinking about some type of anxiety disorder. And so we can have two problems that coexist. So depression and anxiety, we often see happening together. And so we potentially can give both a depression diagnosis and an anxiety diagnosis, as long as they both kind of seem to be, that we can separate them and say that they're both kind of separate problems that are occurring at the same time. One critique of what we often see as very common comorbidity, though, when we're looking at diagnostic assessments, meaning that comorbidity is usually the rule, that we expect to see lots of different types of problems when we're giving diagnoses. That one common critique is that maybe our system of diagnosis is not as well defined as it should be. That a really well-defined system wouldn't see so much comorbidity in our diagnoses that we're running into. So that's one of the kind of questions and controversies that's happening in the field right now. But again, I just wanted to point out kind of this difference between differential diagnosis versus comorbidity, and the idea that mental health practitioners are having to think about both kind of simultaneously during diagnostic assessment. Outcome assessment is the third goal of assessment, kind of third main goal of assessment. Again, what we're doing there is that we're aiming to track how a person is doing in their treatment process, whether they're improving or not, and try to have some data that is as objective as possible in terms of supporting our inferences, supporting our ideas about whether they're improving or not. So with outcome assessment, again, part of why this is given some attention in the textbook is because it's a big topic in the past 10 or 20 years or so. Historically speaking, and even now in certain clinics, the way the outcome assessment is done is that the therapist, after they start treatment with a client or patient, will check in with them each week or however often they're meeting, and towards the end and say, how are things going? How do you feel like our treatment is going? And I kind of rely on the client to give their self-report about how things are going. But you can imagine that's kind of a bit of pressure for the person you're working with, who's saying, that's almost like, am I doing a good job in working with you? So there's some pressure there in that sense. There's also the other side of it where if you're paying for it, or if you have a family member who's paying for it, in terms of your services, you don't want to say, no, this isn't working. You want to believe that it's working, right? And so again, that way of asking whether things are getting better is problematic. It's not as effective as it could be. So outcome assessment is something that is more routine, more standardized, more systematic, and by kind of doing those things, it helps us to improve accountability, meaning that a therapist, should hopefully be able to show that what they're doing is helping their clients, helping their patients. More and more different, like insurance, for example, and Medicare, the big, and Medicaid, the big kind of government health insurance program, has been requiring this, meaning that people have to demonstrate that their services are helping people. There's different ways to do that, but that's been a change in the past 10 or 15 years or so, that's been more emphasized. Outcome assessment helps to improve our clinical and counseling research, meaning that we can get more data about when people are changing in treatment and sort of what helps them to change, excuse me. And then ideally, it helps to improve the overall effectiveness and efficiency of a system of care. So when we have a clinic, when we have a A hospital, we have a managed care plan that when we collect outcome data and progress data for the clients that are being seen, that we start to learn who's doing a really good job in treating their clients, where are the places in which maybe we're not doing as well, and where can we get better? What should we keep doing? Those are the types of questions that we can think about. How do we get more efficient in the services? Where are places where we maybe can say, fewer sessions is okay? Where do we need to add more sessions? So outcome assessment is really crucial in terms of the mental health ecosystem. And I've done some research on this. So to me, it's a topic that's of really big interest. Let me just give you a couple of ideas of how this looks, just from my own experience in doing this. And I wanted to, again, present this, the two different terms, nomothetic and idiographic. So this first slide is on nomothetic measures. Nomothetic measures are measures that where we have like a group comparison, or where the scores are standardized. We can see where someone falls relative to other people who filled out the same measure. And one good example of that would be the PHQ-9. This is actually real session data, real progress graph from a client that I worked with many years ago, but I thought would be kind of a good way of showing this. So the PHQ-9 is a 9-item questionnaire on depression that can be administered weekly. It can be administered frequently across treatment to see how someone is doing as part of this treatment. And the scores can range. So again, we have the y-axis here. On this x-axis is session number, and it's also kind of the beginning date of when the assessments first started and sort of the last available date. And then for the PHQ-9 from the software, you have the different severity kind of bands or parts of the rating scale. So you can see where a person is falling. And this client initially started out about a 15. It went down a little bit, but then came up again. That's pretty normal in terms of the beginning of therapy, where the scores maybe go up a little bit. Maybe people are getting more comfortable reporting what's going on. Maybe they're getting more insight into, oh, actually, yeah, no, that's depression when I'm laying in bed. So I need to make sure I'm reporting that accurately. So for this person, their scores went up a little bit, and then it goes down pretty notably down to the mild level, then comes back up a little bit. And so again, this gives me an ability as a clinician to say, things are going well, things are going well. Okay, wait a second, what's happening? We're kind of going back up. Let's talk to the client about this, have a discussion, make it collaborative so that we can make sure that the treatment is going in the right direction. The symptoms aren't going down. Why might that be? What do we need to change up? Have we stopped doing something that was helping? Do we need to add something back in? Do we need to do something new? Has a client kind of plateaued because they're feeling bored, or another life stressors come up? There's lots of different explanations. But the considerations of choosing measures when we're thinking about nomothetic measures for outcome assessment is that we want to make sure that we're paying attention to what is the purpose of the measure, make sure it's a good fit for outcome assessment. The PHQ-9 is. We need to make sure it has good psychometrics. We'll talk more about psychometrics in a subsequent lecture video. Incremental validity, that has more kind of added information above and beyond the other measures that we're already using. And maybe the only other measure is that weekly check-in, that, hey, how are things going? So the PHQ-9 would have incremental validity over that, but maybe we're already doing other measures, and maybe it doesn't have incremental validity. We want to think about the efficiency and burden. So with only 9 questions, this measure is efficient. It's quick. It's a couple minutes max to fill out. Low burden, but there are measures that are longer. If you're including measures for example, for anxiety, for substance use, as you start to get more problems that you're working on, more goals, then you can start to get more of a burden for these types of nomothetic measures. There's also idiographic measures, and these are individualized measures where we don't necessarily have like a comparison to what would be like good or bad or high level or low level, but we are able to say what is kind of the norm for this client and what signifies improvement for this client. So this is an example from some work, again, that I did with that same client that I just showed. This client was experiencing obsessive compulsive disorder, meaning distressing thoughts about lots of different types of issues, but for this client, it was about things being unclean, and then rituals or compulsions, so behaviors that the client engaged in to address those fears and those feelings of anxiety. And so some of those things that we identified as like the biggest problems, the biggest kind of things that were getting away with this client doing things that were in his life were things like cleaning off clothes in the morning, cleaning off items at work, hand washing, cleaning off items at home, and then we track the total time. So the client would go in, for each day, fill out the amount of time that he was spending in each one, and it would automatically create this total. That created, I was able to create a graph to kind of show how long the client was spending doing these various things and track it across our time together in therapy. And so some of these things don't change a whole lot across the course of treatment, but I think it's pretty evident that there's some notable decrease in terms of the total time that the client is spending doing these different rituals, different behaviors. So it goes from about 350 minutes per day down to an average of about 200 minutes per day. That's still a lot, but again, you can imagine that a difference of 2.5 hours or so would be a pretty big gain for someone to have in their life, that they're spending 2.5 hours less doing these different rituals in their day. So this is one example. Another example would be a progress record that we would have in the course of treatment. So this is from workbook, Master of Your Anxiety and Panic workbook. And basically the client would be tracking the number of panic attacks per week across treatment. So maybe the treatment is going 15 sessions, maybe it's a little bit shorter, maybe it's a little bit longer, but they're basically tracking by putting a little mark for each week, how many panic attacks, and they would fill it in for number of panic attacks, and then they would have an open circle for their rating of average anxiety, and they might rate it on 0 to 12 or maybe 0 to 10 or whatever makes sense. And then we would draw a line through that to have a graph to see how that person is doing. And it's really, we're not comparing it to anyone else. We're just saying, how are you changing over time? And are you changing in the way that we might expect or hope for? Or are you staying the same? Are you getting worse? If so, what do we need to do in our treatment? So idiographic measures are a nice way of doing outcome assessment alongside those nomothetic measures that are maybe more standardized. So we've talked about three main goals of assessment, or three main uses of assessment, ranging from screening, that broad kind of assessment where lots of different people will see assessment measure. We can identify people who are more or less at risk. We're thinking about things like sensitivity and specificity in particular. Diagnostic assessment, we're gaining a lot of information using a lot of different tools. Again, I mentioned I prefer semi-structured assessments. I prefer to use behavioral observations and assessments as well. Prefer to get personality data, neuropsych data where possible. Prefer to get collateral report where possible. So diagnostic assessment uses all available information to say this diagnostic label best fits what this person is describing to me and what other people are describing. And then we have outcome assessment again. How is our treatment progressing? Is it going as we expect it to, which is in the positive direction? People are getting better, or are people staying the same or getting worse? And if so, how do we use that data to make some treatment decisions and change things up in some different ways? So that is it for this part of the lecture, and look forward to a couple more, talking about psychometrics and different measures that can be used in assessment, as well as the diagnostic system.